Okay guys, so we have started a series of lectures on cystic diseases. So far we have discussed adult autosomal dominant polycystic kidney disease. Today we're going to discuss autosomal recessive polycystic kidney disease. And these come under the heading of hereditary polycystic kidney diseases, which I have explained already that there are few more types. The most common among them are adult polycystic, autosomal recessive, autosomal dominant, and apart from that, von Hippel-Lindau and tuberous sclerosis. So we'll come to that one by one. But today the topic is adult autosomal recessive polycystic kidney disease. So these are some of the terms which I have taken from my own notes. I hope this is going to help you a lot in your preparation for board exams and anything like that. So by definition, autosomal recessive polycystic kidney disease, it's a severe disease and it has early onset, and it involves primarily kidneys and biliary tract. We discussed in autosomal dominant polycystic kidney disease that it is also a multisystemic disorder, but autosomal recessive, they primarily target the kidneys and the biliary tract. So how are you going to differentiate? There's a question which more often shows up in the board exams, and it's like if a patient is having multiple cysts in the liver and in the kidneys, and there is some sort of organomegaly like splenomegaly, there's jaundice, there's deranged RFTs and LFTs. So what is your possible diagnosis? In options, there is also ADPKD. So first thing comes into our mind is, okay, there's a cystic condition, there's a cystic involvement, there's a family history, there's involvement of the liver, the kidney. So we can, no, but that's not the case. If this kind of question comes with the involvement of the biliary tree, because deranged LFTs are, it points towards some sort of problem in the biliary tree, which leads to elevated liver enzymes. So the primary diagnosis is autosomal recessive polycystic kidney disease, keeping in mind the history, keeping in mind the age of onset, keeping in mind other factors as well, but this is primarily the case. Okay, so if we talk about genetic basis, so it's a recessive condition and it's a single gene mutation, and primarily the gene is PKHD1, polycystic kidney hepatic disease 1, and the largest protein product of this is fibrocystin polyductin complex. This is the most important protein product which you need to remember, because it's often asked. What is this configuration? It's a one membrane spinning domain and it's intracellular cell terminal. Basically, the function of this FPC complex is to control, or you can say it has a developmental control over the configuration of the collecting duct and the biliary tree. So it leads to, if there's some kind of disruption, so there might be some saccular dilatation or cyst formation in the biliary tree, and the normal epithelia won't remain normal because of the dilation. So pathogenesis involved, it usually begins in utero, and we discussed that there is renal cystic lesion appearance with mutation in this polycystin cystic kidney and hepatic disease 1, which encodes for the gene complex, which is fibrocystin polyductin complex. It's basically a transmembrane protein and found in the mitotic spindles and microtubules. Basically the primary cilia in the biliary tree and the renal tubular epithelium. So basically the whole microscopic mechanism of this protein derangement, it halts or it decreases, or it you can say it disturbs the normal homeostasis of this ciliated epithelium or the renal tubular epithelium. If that tubular epithelial lining is disrupted, let me just give you a brief. This is the epithelium. This is the normal epithelium. It's lined by cells, and usually sometimes they are ciliated. If this is disturbed because of the mutation that has been occurred in PKD-HD1, which encodes for a protein called FPC, fibrocystin polyductin complex. So what happens is that the normal epithelium that's disrupted, the cells are disrupted, so it leads to a saccular dilatation. It leads to a dilatation in that very area because the integrity of the cell is lost, integrity of the epithelium is lost, and it leads to cyst formation in that very area. It could be liver, it could be kidneys. So in both cases, it can happen. So what happens is that mutation of the FPC in abnormal fusiform and saccular dilatation of the collecting and abnormal remodeling of the biliary system, which leads to renal cystic disease and progressive portal fibrosis. So it's the liver manifestation of autosomal recessive PKD is that it causes congenital hepatic fibrosis, or you can say hepatorenal fibrocystic disease. The primary cilium appears to be normal, and sometimes it is considered under a broader term just called ciliopathy, because that's the primarily defect, and which leads to defect in the kidneys as well as in the liver. Coming to the epidemiology, so PKD is 1 per 20,000 live births. Clinical manifestation, as I told you, that it can be in utero and it can occur later in life. In utero presentation is usually enlarged echogenic kidneys with a poor CMD and poor kidney functions and oligohydramnias. Usually they present with a Potter sequence, which consists of what is Potter sequence? So it consists of pulmonary hyperplasia, characteristic facies, spine and limb deformity. These children usually have urine concentrating defect and volume depletion. The overall perinatal mortality, it's 25 to 30%, and the ESRD, they reached about 60% reach about ESRD about the age of 10 years. So infants who have serum creatinine levels of 2.2, they progress to ESRD by the age of 5. So it can be variable depending upon different children. In children who present later in childhood or adolescent, portal hypertension is a frequent presentation. Who are presented late, so they present with the liver complication more as compared to the kidney. Kidney involvement is there, but the liver predominates the kidney. So it presents with hepatosplenomegaly, bleeding diathesis, bleeding sufficient, gastric varices, hypersplenism, thrombocytopenias, anemia, and leukopenia. So these are the complications. Sometimes they present with a hepatic fibrosis, which is non-obstructed dilatation of the ducts, which is called Caroli syndrome or Caroli disease. So that must be kept in mind. So these patients, if you are considering about the possible outcome, so transplant, they need combined liver and kidney transplant, because both the organs are involved. If you treat one and leave the other, the disease is not going to remit, because you have to transplant both the kidney and the liver. Pathology, as far as we know that it involves the kidneys. So in kidney, usually there's a bilateral involvement. They become large symmetrically, and histopathology, the extent of the cystic involvement. In units, 10 times the normal size. The kidneys are 10 times normal size, and but the good thing is that they maintain the typical contours. The contour is not disturbed, but the size, they become bigger and bigger. Dilated fusiform collecting ducts and radially through the cortex. Histopathology shows that there is dilated medullary collecting ducts, and if eukaryotes has more spheroidal appearance. Up to 90% of the collecting ducts involved in interstitial fibrosis and progressive disease. If a child presents in the later childhood, so cyst can be expand up to 2 centimeter in diameter, which is quite high, become more spherical. Like the normal contours can be distorted, become circular. And there is a progressive fibrosis and secondary tubular obstruction. Medullary ductal ectasia is a predominant finding in older kids. So if you talk about the liver involvement, so it's we discussed already that there is involvement of the liver sometimes predominate, but the liver involvement is there, and which leads to ductal plate malformation. The liver can either be normal size, can be enlarged. Biliary ducts are usually dilated, and sometimes cause a biliary ectasia, and the ductal dilatation is sometimes called Caroli syndrome, which is non-obstructive, but there is dilatation. And older to kids, it's located in the periphery, in the portal tract, and other small portal vein branches and portal tract fibrosis and hypoplasia of the portal tract is there. So far diagnosis is concerned. Diagnosis is by imaging. Imaging shows poor corticomedullary differentiation and due to hyperechoic medulla in age 1 to 2 years of the children. And subsequently, there is radially array dilated collecting ducts from the cortex to the medulla on a high resolution scan. So if you see, let me just there'll be some radial arrays. If you take a cross section of this, so it will appear like that. Radial arrays towards the medulla. So that's going to be and of course the size of the kidney is going to be enlarged, CT, and usually there is pelvic atelectasis and renal calcification, because the normal function of the kidney is not disturbed, hemostasis is disturbed, so the kidney cannot maintain its normal function. That's why it can comes with complications like renal calcification. And genetics, of course, play a very important role in the diagnosis, and we know that the principal gene is PKD1, and genetic testing is available. It's a diagnostic tool. The mutation rate is detection rate is 80 to 87%, which is quite high, but sometimes it's not done or neglected, and the patient then present with such type of sequelae. So far the treatment is concerned, so as there's kidney involvement, so the blood pressure should be our main concern, and that's usually controlled with the RAS inhibitors and angiotensin aldosterone inhibitors, and thiazide diuretics are sometimes used because of the concentrating defect and polyuria. And you should maintain a high index of suspicion of ascending cholangitis, because the biliary tree is involved, and as the biliary tree is involved, so it can lead to some inflammatory response and infection as well. So if there is some kind of this, there's a triad for this: increase liver function test or deranged liver function test, and there's febrile episodes with right hypochondrial pain, so you should suspect cholangitis in that case. Of course, transplant is the ultimate treatment in a patient who has become ESRD or on the verge of becoming ESRD, but as I told you, that combined liver and kidney transplant is considered. Doppler studies shows a good surrogate marker for portal hypertension severity, and in this way you can we can signify the extent of the disease involvement and the portal tract involvement and its consequences, because if there's portal hypertension, there's going to be consequences for that as well. If a parent chooses to donate his or her kidney or liver for that matter, so the imaging should normal, and due to the recessive nature of the disease, it usually does not manifest. So they should undergo extensive thorough workup, genetic workup, in order to rule out any defective gene in that case. So that's all about autosomal recessive polycystic kidney disease. And just to summarize what we have discussed so far is that autosomal recessive polycystic kidney disease, it's a disease of neonates or children of older age. What is presentation? It presents with renal dysfunction and liver dysfunction. Among renal dysfunction, it can be cystic dilatation or cystic condition, cystic kidney, and also it can present with defective concentration of the urine, and sometimes stones. If we talk about the liver involvement, so the liver involvement, it presents with this biliary tree involvement. Biliary tree is involved, and it leads to cyst in the biliary tree, cystic dilation. And apart from that, it can lead to hepatic fibrosis if it's severe hepatic fibrosis, and portal hypertension, and usually presents with the syndrome which is called Caroli syndrome. So Caroli syndrome is basically, it's a sequelae of liver involvement in AR PKD. So one should be, and moreover it can also present with complication like ascending cholangitis if there is on and off inflammation in the biliary tree, so it can present with that. So the genetic basis, the gene involved is, as we know, that it's PKD1. It encodes a protein which is called fibrocystin polyductin complex, right? And how you can treat these patients? So the treatment lies with them what they present with. Like, first and foremost thing is the blood pressure control via RAS inhibitors, and secondly, best treatment for these kind of patient is combined liver and kidney transplant, and then treat the complications. Like if there is concentrating defect, you can use thiazide diabetic. Moreover, if there is a liver involvement, so you should go for the best modality of choice for these patients is transplant, which is combined liver and kidney transplant. So that's all for the adult polycystic kidney disease. We'll come up with some other cystic conditions. So far we are discussing genetic causes of cystic kidney diseases. So just to be on track, we are going to discuss in the next lecture tuberous sclerosis and von Hippel-Lindau syndromes. Thank you so much, and please do subscribe to my channel. Thank you.